Hi, you've arrived at a COPD patient's home. They're more short of breath than usual. They're using accessory muscles to breathe, and they're coughing up thicker sputum than they were last week. What should you document? Well, instead of guessing, use the simple framework: condition, risk, skilled action, response, and then continued need. Let's walk through a real COPD visit and see how experienced home health nurses think. Imagine you're seeing a 76-year-old patient with COPD. During the visit, you observe increased shortness of breath with minimal exertion. Productive cough with thick yellow sputum. The oxygen saturation is 89% with activity, and patient reports increased fatigue over the last several days. Many nurses would simply document those findings, but Medicare wants more than findings. They want to understand the clinical story. So, step 1, ask yourself, what is the most significant clinical issue today? Well, today's condition is increased dyspnea, increased sputum production, and decreased activity tolerance. These findings may indicate worsening COPD symptoms or a developing respiratory infection. That's the clinical issue that really matters. So step number 2 is the risk. What bad outcome would happen if this condition continues? Well, the patient is at risk for COPD exacerbation, respiratory distress, pneumonia, an emergency room visit, or even a hospitalization. This is where medical necessity becomes obvious. The story isn't shortness of breath. The story is the risk created by that shortness of breath, if it's to continue. Skilled action. Why was a nurse needed today? Well, a family member, they can notice coughing. A nurse can assess respiratory status, evaluate oxygenation, interpret symptom progression, and assess medication effectiveness, reinforce disease management strategies, and identify when a doctor notification is necessary. That's skilled nursing judgment. Today's skilled actions may include respiratory assessment performed, lung sounds evaluated, oxygen saturation assessed, inhaler technique reviewed, energy conservation strategies reinforced, education provided regarding exacerbation warning signs, and MD notified of symptom changes as indicated. And then step number 4 is the response. Ask yourself, what happened because of your interventions? Maybe the patient demonstrates proper inhaler technique after instruction. Maybe they correctly identify symptoms that require a doctor notification. And maybe they continue to need reinforcement. Document the response. This shows the effect of your skilled intervention. And then step number 5, the continued need. Why are future nursing visits still needed? This patient continues to demonstrate unstable respiratory symptoms, limited understanding of disease management, and risk of COPD exacerbation. Need for ongoing skilled respiratory assessment. That supports continued skilled nursing services. So, putting it all together, now let's turn the visit into a clinical story. Patient noted with increased dyspnea on minimal exertion, productive cough with thick yellow sputum, and decreased activity tolerance compared to previous visit. Oxygen saturation decreased to 89% with ambulation. Skilled respiratory assessment performed, including evaluation of breath sounds, respiratory effort, oxygen saturation, and symptom progression. Medication regime reviewed and inhaler technique assessed. Education reinforced regarding medication adherence, breathing techniques, energy conservation, and signs and symptoms requiring a doctor notification. Patient able to verbalize some exacerbation signs and symptoms, but continues to require reinforcement regarding disease self-management. Physician notified of worsening respiratory symptoms for further evaluation. Continued skilled nursing required due to risk of COPD exacerbation, respiratory decline, and possible hospitalization. What the Medicare reviewer perspective sees in all this is condition. They understand that it's increased dyspnea, sputum production, and reduced activity tolerance. The risk, COPD exacerbation, respiratory compromise, and possibly going back into the hospital. The skilled need, respiratory assessment, symptom evaluation, teaching and care coordination, skilled intervention, clinical assessment, education and physician communication, and continued need. Patient remains at risk and requires ongoing skilled monitoring. This is the clinical story that Medicare wants to see. So in closing, the next time you're documenting a COPD visit, don't just chart symptoms. Ask yourself, what's the condition? What's the risk? Why was a nurse needed and what skilled action occurred? Why are future visits still necessary? When you think through those 5 questions, your documentation becomes stronger, your clinical reasoning becomes clearer, and your notes naturally support medical necessity and skilled nursing services. Because great documentation isn't about documenting more, it's about documenting what matters. Thank you for stopping by. If you would like, there's more information on the channel, and consider subscribing if you found value in this. Thank you, and see you on the next one.